could be due to calcium deposition in the pancreatic duct or due to calcium's ability to activate trypsinogen in the pancreas. Pancreatitis here is symbolized by our recurring sketchy symbol, a squeezed pancreatic sponge. And everyone's favorite part of the rhyme, psychiatric overtones. Nerve conduction abnormalities and hypercalcemia can lead to confusion, anxiety, psychosis, and even seizures. Just think of this mad PTHD scientist with those crazy eyes.
Buy ice cream. Tell your friends. Your parents will try to stop you. If you don't eat ice cream, you'll perish in a fiery grave.
Gah! That was... Oh, you didn't... Nothing. Where was I? Yeah. Remember that these neuropsychiatric symptoms are rare and almost only occur with dangerously elevated calcium levels. All right. Before we move on to secondary hyperparathyroidism, I want to briefly discuss treatment. Symptomatic patients will need parathyroid surgery. It's the only definitive cure. Before surgery, doctors can use many different imaging techniques to find the tumor, including a technetium 99M sestamib radionuclide scan, represented here by this book of 99 dessert techniques. Gotta memorize that thing cover to cover if you want to pass the PTHD program, my friend. During a sestamib scan, the radiotracer is taken up by the mitochondria of the parathyroids, especially in active tissue like an adenoma. After you find it, cut it out. One last thing about cutting it out, though. After surgery for correction of hyperparathyroidism, the patient can experience something called hungry bone syndrome. It goes a little something like this. With high PTH levels, osteoclast bone breakdown is dominating the scene, as we conveyed with those hungry classmates down there. After surgery, however, the abrupt drop in PTH allows osteoblasts to pull forward, leading to a marked increase in bone mineralization. This is depicted by the osteobuilder installing that new bone bookcase. The abrupt increase in deposition of calcium and phosphate leads to a precipitous drop in calcium, phosphate, and magnesium levels. Hence the calcium ice cream, phosphate peas, and magnesium magazine getting knocked to the floor during construction. Hungry bone syndrome can occur up to several days after surgery and is readily treatable by electrolyte replacement. Well, that's it for primary hyperparathyroidism. Time to hit up the pickup counter. The sign with the number 2 is here to designate secondary hyperparathyroidism. We're still going to have elevated parathyroid hormone, embodied by the PTHD at the counter. But this time, it's not caused by pathology in the parathyroids themselves, but pathology in the kidney. See those 2 crumpled sample cups? How they look kind of like small shriveled kidneys? They represent chronic kidney disease, the culprit behind secondary hyperparathyroidism. In chronic kidney disease, impaired 1-alpha hydroxylase leads to decreased synthesis of 1,25-dihydroxyvitamin D, or calcitriol. Hence our malfunctioning calcitriol robot over here. I think that's a malfunction.
I've seen things you people wouldn't believe.
Okay. Well, what we're dealing with here is vitamin D deficiency, which means less retrieval of calcium from the GI tract, among other calcium regulatory functions, and in the end, hypocalcemia. Let's emphasize hypocalcemia in secondary hyperparathyroidism by watching our calcium ice cream order, which we've been waiting for a good 20 minutes now, drip slowly to the floor.
All these moments will be lost in time. Like
Both vitamin D deficiency and the subsequent hypocalcemia lead to direct stimulation of the parathyroid glands, which start cranking out parathyroid hormone in a futile attempt to correct calcium levels. Furthermore, renal retention of phosphate in the setting of CKD causes hyperphosphatemia, symbolized by those P-shaped mixers still attached. Serum phosphate acts as another direct stimulator of parathyroid hormone release. Remember, parathyroid hormone is normally responsible for increasing phosphate excretion by the kidney, which is why those P-shaped mixers were dropping to the floor last time. So it only makes sense that in the setting of kidney failure and too much phosphate floating around, parathyroid hormone levels increase in an attempt to bring those levels back down. Again, this is called secondary hyperparathyroidism. To recap, the laboratory profile shows low calcium, low vitamin D, and high phosphate, all because your kidneys ain't working. This drives an elevated PTH. In fact, chronic stimulation of the parathyroids to produce hormone in the setting of secondary disease leads to diffuse parathyroid hyperplasia. So we've also brought back those big, oversized buttons. Be sure to distinguish this from primary hyperparathyroidism, which is sometimes associated with hyperplasia too. The key is that in primary disease, you'll see hypercalcemia due to overactive parathyroid. In secondary hyperparathyroidism, you have hypocalcemia due to kidney disease.
I've done questionable things. Questionable things.
Jeezy crazy, Calcitron, can you stop? Now is not the time to be handing out loyalty cards. You're scaring him. You know what? Power down, Calcitron. I said power down! Ugh. Anyways, take a look at the punched out loyalty card. Since PTH levels are high, that means patients with secondary hyperparathyroidism commonly get bone disease, including osteitis fibrosis cystica. You'll also see an elevated alkaline phosphatase on labs. So we've placed another box of chalk up on the counter. Check out the chronic kidney disease sketch at the Jurassic Park Museum for more info on all the clinical manifestations of chronic kidney disease, including bone disease. Treatment is easy when you think of the metabolic derangements in secondary hyperparathyroidism. Low calcium? Supplement calcium. Low vitamin D? Give calcitriol. Not precursors, since 1-alpha hydroxylase is in the toilet. But straight up 125 dihydroxyvitamin D. Hyperphosphatemia? Good call. Phosphate binders. But that doesn't always work so well. In about 25% of cases, even with optimal medical therapy, secondary is not treatable without surgery. Here's a twist ending for you. It turns out that if secondary hyperparathyroidism continues long enough, it can transform into what's called tertiary hyperparathyroidism, which we'll illustrate around that number 3 table. Notice that we still have those crumpled cups. Yep, still dealing with chronic kidney disease here. Normally, in CKD, hypocalcemia, low vitamin D, and high phosphate stimulate the parathyroids. That's secondary. In tertiary hyperparathyroidism, however, all that stimulation the parathyroids are receiving suddenly activates
Beast mode.
The parathyroids undergo marked nodular hyperplasia, and these massive glands secrete equally massive amounts of parathyroid hormone, completely autonomously, regardless of serum calcium levels. The classic lab findings associated with tertiary hyperparathyroidism include markedly elevated parathyroid hormone levels, as well as hypercalcemia from increased bone resorption. This is why we have all that calcium ice cream raised in the air. All that bone breakdown also causes phosphate to leak into the serum. With no functional kidneys to excrete it, you should also expect hyperphosphatemia, represented by the P-shaped phosphate mixer he's using to fend off those ravenous kids. And lastly, this is chronic kidney disease after all. So you still have low vitamin D. Man, those kids are ruthless.
Their little hands were everywhere. Everywhere!
Kids. This state makes patients especially vulnerable to metastatic calcification, in which calcium phosphate is deposited in tissues throughout the body, including the kidneys, skin, brain, heart, and lungs, all depicted by the calcium ice cream showering down on the kids below. In tertiary hyperparathyroidism, the only treatment is parathyroidectomy.
Want to hear what a real scream for ice cream sounds like?
As the parathyroids are no longer responsive to electrolyte correction, sometimes even after renal transplant. Well, that escalated quickly. I think it's time to close up shop with a brief discussion of hypoparathyroidism. Maybe calm things down a bit. We're going to illustrate hypoparathyroidism in the ice cream lab break room, where the PTHD scientists toss off their white coats and unwind after a long day of confectioning? Concocting? Concocking? Anyways, you see how the white coat hooks are kind of scalpel-shaped, causing one of the PTHD coats to fall to the floor? Well, most cases of hypoparathyroidism are actually iatrogenic, caused by damage to the parathyroids during thyroid or parathyroid surgery, or head and neck radiation, as symbolized by the radiation symbol on the microwave in the back of the room. Notice that some of the hooks are oddly antibody-shaped too. Following iatrogenic causes, Autoimmune destruction makes up most cases. The most common autoimmune disease affecting the parathyroid glands is called type 1 autoimmune polyglandular syndrome, represented by the various gland-looking hats hanging on the antibody hooks. This disease can cause permanent hypoparathyroidism and other endocrine disturbances, such as adrenal insufficiency, hence the adrenal beanie hanging up there too. The most common and most commonly tested cause of congenital hypoparathyroidism is an association with DeGeorge syndrome, depicted here on the back of the break room wall by the inspirational poster of George Washington crossing the Calcium River to surprise the British with delicious flavor. I don't know history. Recall that DeGeorge syndrome is caused by a 22q11 deletion leading to abnormal development of the third and fourth branchial pouches. And what comes from the third branchial pouch? The parathyroids, of course. Check out the immunology unit for more about the clinical features of DeGeorge and other causes of cell-mediated immunodeficiency. In the setting of hypoparathyroidism, expect to see hyperphosphatemia. Remember, parathyroid hormone is crucial for dropping phosphate at the kidney. Parathyroid hormone is also responsible for calcium reabsorption in the kidney, making vitamin D, and releasing calcium stores from bone. So the big picture here in hypoparathyroidism is hypocalcemia. The characteristic symptoms of hypocalcemia will be represented by the various hijinks going on in the break room. Symptoms of acute hypocalcemia can be mild, such as perioral numbness or paresthesias of the hand and feet. You know, just a harmless prank. No biggie. The more severe manifestation of acute hypocalcemia is tetany, which manifests as muscle cramps or even severe muscle spasms. Two classic physical exam findings seen in this state of neuromuscular irritability are Vostek sign and Trousseau sign. Vostek sign is twitching of the face caused by tapping of the facial nerve. Just think of this guy tapping his friend in the face with that spoon, watching him twitch in response. It's like more of a hazing than a prank. Trousseau sign is a spasm of the hand caused by occlusion of the brachial artery with a blood pressure cuff. Just think of this guy holding pressure down on his friend's arm, causing his hand to clench in fear as his friend tries to escape. Okay, this just went from hazing to assault. Neurological signs in hypocalcemia can range from anxiety to seizures and even psychosis. So don't forget to George Washington's inspirational message to seize the dessert. Seize it. Another important clinical manifestation of hypocalcemia involves the heart. Low calcium can impair the contractility of the heart and arterial tone, which can lead to heart failure, hypotension, and shock. We'll represent negative effects on the cardiovascular system in general by including our floppy failing heart balloon, left over from the last ice cream party. In any case, hypocalcemia tends to be mild as opposed to severe, and often correctable with correction of the underlying disease, calcium, and vitamin D supplementation. Welp, that concludes our tour of the ice cream lab. Brief recap time. Primary hyperparathyroidism? Well, it's usually from an adenoma. It causes increased parathyroid hormone, which leads to increased vitamin D, and increased calcium from the bone, GI, and kidney. Decreased phosphate, by the way. Parathyroid hormone makes you pee it out. Then there's secondary hyperparathyroidism, due to chronic kidney disease. That means you have vitamin D problems, and thus low calcium. High phosphate, by the way, because now you can't pee it out. Lack of calcium, vitamin D, as well as high phosphate stimulate all four glands to increase parathyroid hormone release and get all hyperplastic and stuff. And might even send the parathyroids into tertiary mode. That means lots of parathyroid hormone, lots of calcium from bone, still can't excrete that phosphate, so, that too. Whatever the cause of hyperparathyroidism, expect all that parathyroid hormone to cause wacky osteoclast-mediated bone stuff. And finally, the symptoms of hypercalcemia. Stones, thrones, groans,
And psychiatric overtones. Buy ice cream, buy ice cream, buy ice cream.